Hello, my name is Ricardo Arbulu. I am a clinical faculty at the University of Pittsburgh Medical Center. And today we will discuss why should antimicrobial stewardship programs systematically plan on intervening in the risk stratification of patients who carry a penicillin allergy label in the EMR or per self-report. And we will discuss an algorithm that has been successfully applied in several centers across the US. Why is this important? Penicillin is the single most frequent drug allergy in the United States. About 10% of the US population claims a penicillin allergy, and this goes up to 15% in those hospitalized. Yet, 95% of people with this label can eventually go on to receive a penicillin. The main problem is that the penicillin allergy label in the electronic medical record negatively impacts the patient outcomes. There are 4 reasons why penicillin allergy labels are frequently inaccurate. The first one is that type 1 IgE-mediated hypersensitivity reaction does wane over time, and this includes severe reactions, namely anaphylaxis. When people with a positive penicillin skin test have been followed 10 years later, it turns out that 80% of them are tolerant of penicillins. A second reason is the existence of this most common reaction, a delayed benign morbilliform rash. This is felt to be probably T-cell mediated, although not perfectly well understood. The importance of this rash, in addition of it being benign, is that only about 10% of people will recur on re-exposure. And these figures come from studies in children. The course in adults is less well known, but it's believed to be around the same. This is how the reaction looks. So a typical morbilliform rash, maculopapular, at times only macular. The presence of pruritus is variable, and when it fades, or when it heals rather, it heals by fine desquamation. Most importantly, this is not an immediate reaction, but rather a delayed one that may even occur after discontinuation of the drug. But in our practice, we can attest that this is very common, as opposed to the more classic IgE-mediated hypersensitivity reaction that, as the name implies, is immediate. And you can see here an example of hives. Many patients are simply or were never allergic. The most common description in the penicillin allergy labels is either an unknown reaction or a blank. And there's a long list of adverse drug events that we see in clinical practice that do not warrant withholding penicillins, let alone cephalosporins, from patients, and that can be anticipated and managed or simply may not recur. A fourth and final reason is this well-described phenomenon of a cutaneous reaction in the setting of concurrent viral infection. This is typically seen in the setting of Epstein-Barr virus with the administration of amoxicillin in children. And this, again, does not recur. So there are several reasons why these labels negatively affect patients. The avoidance of cephalosporins under the belief that there's a high risk of cross-reactivity tends to lead to administration of broad-spectrum antibiotics. And this was illustrated by Acker in this example of in gram-negative rot bacteremias. The alternative antibiotics tend to carry increased risk for adverse events, such as clindamycin and vancomycin, with an increased risk for CDI, Clostridium difficile infection, and acute kidney injury, respectively. Most importantly, the alternatives may not be as efficacious. In this study by Blumenthal in 2018, she showed that people who received clindamycin or vancomycin in order to avoid cefazolin as perioperative prophylaxis ended up having a greater risk for surgical site infection. Lastly, there is an increased cost in most of the alternatives involved. And here's an example of aztreonam versus piperacillin tazobactam. But the most important cost increment comes from all the missed opportunities and the unwarranted side effects that occur and may lead to longer hospitalizations. Even though it is popularized in the medical profession that there is a 10% risk cross-reactivity between penicillins and cephalosporins, the actual observed cross-reactivity in well-designed studies after the year 1980 is consistently less than 2%. And I specifically list 1980 because studies in the 70s were done at a time where cephalosporins were produced in facilities that also produced penicillins. And therefore, there was the possibility of cross-contamination, invalidating the results. The cross-reactivity with carbapenems is even lower. And you can see how that correlates with how similar or dissimilar the molecules are. With the most dissimilar monobactams, there is no cross-reactivity. For completion, here is the cross-reactivity between cephalosporins and carbapenems, which is also low. So what actually matters in order to be able to design a strategy to address this is getting more granular and knowing which penicillins cross-react with which cephalosporins. And that cross-reactivity will be largely mediated by this R1 group, which is present in both. The more similar, the more likely to react. In fact, here's an example of ampicillin, which has the exact same R1 group than this list of cephalosporins. And in that case, what we see is that there's a 10% cross-reactivity rate. That's among the highest cross-reactivities that you may expect. So we can aggregate all this data and we can tabulate in a beta-lactam cross-reactivity chart, where we list here all beta-lactams versus all beta-lactams according to their R1 group similarities or dissimilarities. And you can see how a quick glance of this, by the way, these X's that appear are observed reactions. That's why I like this particular table from British Columbia, in which case, so we can see that the empirically observed reactions correlate with the fact that these here share an R1 group. But let's focus on a couple of observations here. Cefazolin has all green checks here because it does not share any R1 group with any other beta-lactam, and there's no observed cross-reactivity empirically. Same happens with the third and fourth generation cephalosporins when compared against the penicillins, amoxicillin, ampicillin, penicillin, etc. So with those two, we can go very far in designing a strategy of risk stratifying patients. So let's look at how this has been incorporated in an algorithm. Variations of this algorithm exist in our institution at UPMC and in other centers, notably Kaiser Permanente and Emory. The basic structure was published by Blumenthal in 2015, and that's what we will follow. So when a penicillin allergy is identified in the EMR, the team must first exclude by history, and this is only by history, and that includes review of the electronic medical record, of course, and many times, mostly review of the electronic medical record. They must exclude this delayed severe type 2, 3, and 4 hypersensitivity reactions listed here. As a generalization, when these reactions involve the skin, which we abbreviate SCAR, severe cutaneous adverse reaction, they involve desquamation and or mucosal damage. And there can be end organ damage in an isolated fashion, such as nephritis, cytopenias, or hemolytic anemia. So when these reactions are present, the general consensus is avoidance of beta-lactams, looking for alternatives. Aztreonam is okay. It is a monobactam, and we just saw that it does not cross-react. If there is, however, a strong indication for penicillin, allergy and infectious diseases should be consulted, and there might be an opportunity for desensitization. But the important point here is that, in general, the presence of these in the chart exclude further protocols or further downstreaming of this algorithm. Also, at this point, I should comment that who conducts these histories? Across the board, pharmacists, physicians, nurses have been utilized to conduct this protocol, but they need training specifically, and goes way beyond what we're just describing here. So if these reactions, the severe reactions, are not present, we are ready to make a first recommendation that may be the basis of a complete intervention or a targeted intervention, such as we're doing currently at UPMC Mercy with the neurosurgery department. So when we arrive to this point, we say it is okay to prescribe cefazolin in the preoperative setting, or period. Many studies have shown this. I quote here this one from Grant in August 2021, at which time 220 patients in the perioperative setting received cefazolin, despite having an allergy listed in their chart, including anaphylaxis, and they did not have any side effect or any adverse reaction, rather. Once we get past this, we need to ask ourselves, are we dealing with an IgE, a history of IgE-mediated reaction? Here are the features of it on a picture of hives. If those are present, the best way to proceed is a penicillin skin test. However, this is largely not available, or not readily available, I should say, and therefore we have this type of risk stratification. At this point, if these patients have not had a severe reaction, as we saw in the previous slide, they are okay to receive a non-cross-reacting cephalosporin. As we just saw previously, the risk is very low. Now, at UPMC Presbyterian Shadyside, we have the additional consideration that if this allergy was already greater than 10 years old, there is a greater chance that patients had outgrown it, that this has waned, and therefore a full dose of a non-cross-reacting cephalosporin is an acceptable risk. If we get past these two more severe tiers or risk strata, we get to the point where we're likely dealing with this benign rash that we described before. If so, or if the patient does not recall the details of the allergy, yet there's no reason to believe it was a severe allergy, we can proceed with dosing non-cross-reacting cephalosporins just in a full dose. The alternative is doing a test dose of cross-reacting cephalosporins. Essentially, the risk is lower, so we can afford to give more doses, not necessarily avoiding these cross-reacting cephalosporins. And I should mention that this test dose procedure that I mentioned, that Kip mentioned, is also known as graded challenge, and it consists in giving incremental doses of the desired medication, not to be confounded with desensitization, which is inducing a temporary state of tolerance that does not persist. If we are past all these types of known reactions, we're probably dealing with a patient who had a miscellaneous adverse event non-mediated by allergy. In these patients, it is accepted that receipt of beta-lactams without restrictions is appropriate. I would like to thank these individuals working towards the management of penicillin allergy at UPMC, and thank you very much.